Because I have a couple of things to tell you about this Grand Rounds. It's a special Grand Rounds in honor of Domestic Violence Awareness Month. I'm going to pause, leave you with that idea. You all know most of that because you're here. And I'm just going to first jump ahead to next week. So the next week's rounds is from Martin Picard, who just joined here a couple of years ago. He's in psychiatry and also in neurology. He's actually in the Division of Behavioral Medicine, where I am located. So he's just a terrific colleague. It'll be a great talk. He's going to discuss a mitochondrial link between brain and body. All right, so it really is my honor to welcome our speaker today. She's Dr. Louise Howard, and you're going to hear a bit of different acronyms or names because she's from across the pond, and I'll be telling you about that. But again, it's our lecture in honor of Domestic Violence Awareness Month, and Dr. Howard is going to be addressing the topic you can see here. I hope they're the same. Yes, how should psychiatric services address domestic and sexual violence? So again, to speak on this issue of why do we have this special lecture here, it's now an annual lecture, and it came out of an initiative which is a private, public, and university partnership to bring enhanced mental health services to the family justice centers which are across New York, and there are now 6 of them, and they are centers that offer co-located legal and social services to people who are in domestic violence situations. And through this partnership, Columbia, and now it's expanded to a team throughout the city, we're charged with bringing really enhanced mental health services. So this partnership is on the private side, supported by the Chapman-Perlman Foundation, and on the city's side from the Office to Combat Domestic Violence. And we're really honored to have the commissioner of that office here, Dr. Cecile Noel. And then again, the third arm of this partnership has been Columbia. And I'm really here representing our team on this partnership, the team at Columbia. Betsy Fiddleson has been leading this with me and really taking the lead recently as the work has expanded to the other family justice centers. And then we have Mayumi Okuda, Rosa Rojenkos, and Uju Obiberry, sorry Uju, really providing excellent clinical services there. And then Deirdre Clifford has been doing administrative work. And now this task is really both direct clinical care in the Bronx. We're pulling back from that, and we're providing more supervision as the Health and Hospital Services, in conjunction with the Office to Combat Domestic Violence, are working together to bring these enhanced services to all of the family justice centers. So again, representing this team, I'm going to introduce you to Dr. Howard, and then she's going to take it away. So Professor Louise Howard, she studied medicine at the University College London and trained in general medicine at Bloomsbury, obtaining the membership of the Royal College of Physicians in '91. After completing her general psychiatric training and obtaining membership of the Royal College of Psychiatrists, she obtained a Wellcome Trust Health Services Research Training Fellowship in Perinatal Psychiatry. She was appointed professor in women's mental health at the Institute of Psychiatry, King's College London in 2010, and works as a perinatal psychiatrist at the South London and Maudsley National Health Service Foundation Trust. She has won a number of prizes for her research, including the International Marseille Society Marseille Medal for Perinatal Mental Health Research. She chaired the National Institute for Health and Care Excellence, that's the NICE, Guideline Development Group, an update on antenatal and postnatal mental health, and was a member of the NICE and then the Social Care Institute for Excellence and WHO Guidance Development on preventing and reducing domestic violence. Her current research includes a National Institute for Health Research Program grant for applied research on the effectiveness of perinatal mental health services and several projects on domestic violence. She was awarded a highly prestigious NIHR research professorship for 2013 and 2018, which also funds her research program. So really a warm welcome to Dr. Howard. Really looking forward to having you.
Thanks, Catherine, and thanks very much for inviting me to speak here. I'm really honoured to be here. As Catherine said, and as my disclosure of interest shows you, I'm actually a perinatal psychiatrist, and you might wonder why I'm here talking about domestic violence. But when I was a medical student and then as a psychiatry trainee, although there was a lot of discussion around child abuse being related to the problems that we were seeing in clinical practice, there was very little, if any, discussion of domestic violence. And when I started in research, supervised by Professor Chani Kumar, one of the early perinatal psychiatrists in the UK, we decided to develop an instrument to look at the health and social care needs of pregnant women with severe mental illness. We wanted to modify a generic instrument called the Camberwell Assessment of Need and make it suitable for pregnant women and mothers with severe mental illness. So we went and asked women what they felt should be addressed in this instrument that wasn't already addressed in the generic instrument. Now, of course, they talked about the emotional demands of childcare and the practical demands, but one of the things that particularly resonated for me was that they said that although people asked them about child abuse, what they didn't feel able to disclose, because they weren't asked, was actually what was happening in their relationships currently. And we therefore decided to include a domain specifically on domestic violence and abuse to this generic instrument when we modified the CAN. We then started to use it, and it's used both by women themselves but also by the staff looking after them. And what we found was even though there were prompts about domestic violence and abuse, the women themselves were often telling us this was an unmet need, whereas the staff weren't actually acknowledging that it was a problem at all. So this got me thinking that actually, maybe as well as perinatal mental health research and practice, I needed to be thinking about domestic violence as well. So I started to wonder what was the relationship between domestic violence and mental disorders, and what could psychiatric services do about this. Now, just to make sure that we all understand what we're talking about when we refer to domestic violence and abuse, the UK definition was modified in 2013 from a pretty broad definition already, covering psychological, physical, and sexual abuse, to also specifically mention coercive controlling behavior. And this was actually put into the legislation in the Serious Crimes Act in 2015 as a specific crime, coercive controlling behavior that somebody could be prosecuted for. So I looked up before I came here to find out what the US CDC definition is, and it also covers physical, sexual, and psychological abuse, and it does specifically mention coercive acts. The main difference is that it only focuses on partner and ex-partner violence, what's referred to often as intimate partner violence, whereas the UK definition also includes adult family perpetration and victimisation. Now, other jurisdictions, such as Australia, actually refer to family violence. And this is because they're not referring to child abuse, they're referring to the children witnessing domestic violence because of the potential harm to those children. And when I was in Australia last year, this time last year actually, the Royal College of Psychiatrists in Australia and New Zealand had set up a working group on domestic violence because of this woman, Rosie Batty. I don't know if any of you have heard of Rosie Batty, but she was somebody who'd had a partner abuse her over the years. She often wasn't actually with him, but she allowed him contact with her child because she felt it was very important that he should see her son growing up and that he would have a father. Eventually, tragically, this 11-year-old boy was killed by his father on a cricket pitch at the end of some cricket that these boys were playing in front of a whole range of people. And she's written a book about her experiences. And what's I think, interesting is thinking about how the domestic violence sector in Australia has been invested in and has really, made great opportunity. It's been a great opportunity for them to get more funding, and this was such a case that was causing such concern. But actually, the psychiatrists in Australia were concerned that although clearly there is a gendered element to domestic violence, which I'm going to talk about, they were also concerned that nobody was talking about the fact that the father was actually psychotic. And if you read her book, although she doesn't really talk about the mental illness in her partner, it's absolutely clear to a psychiatrist that he was actually hallucinating and had various types of paranoid delusions for many years, which were just not addressed by services. So I'm going to talk today initially about the relationship between being a victim of domestic violence and mental disorder, but also talk about perpetration, which isn't something that I ever planned as a perinatal psychiatrist to start thinking about and researching, but it just keeps on emerging. But before I start, I also wanted to just highlight some of the challenges in this type of research. So firstly, most studies focus on physical violence. That's relatively easy to ask about. Most studies don't ask about sexual violence, so are under-recording the extent of violence. They also usually don't ask about psychological abuse. And most surveys, crime surveys, talk about whether or not somebody has ever experienced an incident. And if you focus on whether or not somebody's experienced an incident, then the rates are pretty comparable for men and women. So it looks as if this is a gender-neutral issue. But in fact, and as I'll show you in a minute, there is a gender difference in terms of who is more likely to be a victim of recurrent and severe abuse and also be a victim of homicide, and who is more likely in terms of gender to be a perpetrator. Having said that, clearly both men and women can be victims and perpetrators of domestic violence, but there is a gender issue here. Some people have suggested that it might be more helpful, instead of thinking about incidents, to actually think about different types of domestic violence. And Johnson has talked about different typologies, including intimate terrorism, which is very much focusing on power imbalance and coercive control, compared with situational couple violence, which he describes as lower level mutual violence, where people who've always grown up with violence tend to use violence as a way of disagreeing with each other without it necessarily becoming so severe and recurrent in terms of danger, and also without there being a huge power imbalance. And then also talks about other types of domestic violence. Some people find these helpful, but Sylvia Walby, who's a sociologist and criminologist in England, has suggested that what we really need to think about is being much more specific about what exactly are we measuring. So she highlights that we actually need to talk about what the whole range of actions are, what the intentions were, whether there was actually harm, what is the impact, because impact is important, and whether or not there was consent. And also thinking about measures of seriousness. How repetitive was the violence? What is seriousness? And then also about the unit of measurement. So are we talking about a certain number of events? Who is the victim and who is the perpetrator? And this is when you turn to the psychiatric literature on violence and you think, okay, I'll look at all these studies that have looked at violence and severe mental illness and look to see how much of that violence is domestic violence. And what you find is that often the studies don't report who was the victim. And that's really frustrating because then you don't actually know how much of a problem it is for psychiatric services. So I think we could learn something from Sylvia Walby in terms of thinking about measurement. She also highlights the importance of knowing the sex of the victim and the perpetrator and whether or not there was a sexual aspect to the violence, and highlights the importance of disaggregated measurement. And again, a lot of studies tend to just talk about violence in general and severe mental illness and adjust for gender, and then you can't actually look at the gender differences. So here is some general population data from the US National Intimate Partner and Sexual Violence Survey. They've done a nice infographic to show some of the gender differences there. So 1 in 4 women, according to a US survey, experience severe physical violence, 1 in 7 men. It talks about female victims reporting different patterns of violence, that they're more likely to experience multiple forms of violence, whereas male victims are most likely to experience physical violence. And then they also highlight the huge cost to the medical service and also in terms of productivity to society. Now, the WHO has done a large multi-country study of domestic violence, mainly focusing on physical partner violence. And you can see here that there is geographical variation, but even this infographic from the WHO doesn't really show you just how variable some of these prevalences are. So in Ethiopia, for example, which has the dubious honor of having the highest rate of physical violence experienced by women, over 60% of women said that they had experienced physical violence from their partner, whereas in some countries, prevalence is very low, for example, Japan. And this issue of certain countries where there is great gender disadvantage being associated with partner and sexual violence has been linked to this issue of suicide being the leading killer of adolescent women in certain countries such as India. So clearly a lot of concern internationally about violence, but this is at the general population level. Is this relevant to us? Well, we've written a review in Lancet Psychiatry earlier this year on violence against women and mental health services. And if we think about the general population, then we know that from the WHO ecological framework, one can think about risk factors at the individual level, such as childbearing age women are more likely to be victims of violence. Victims of violence are more likely to have a history of being abused as a child or witnessing parental violence. They're also more likely to be misusing substances, have low self-esteem, and they're more likely to be poor. But it is important to point out that this sort of abuse occurs across social classes. Then when it comes to the relationship, does the partner have specific risk factors? Well, substance misuse, a history of child abuse, or witnessing violence, again, clearly related to perpetrating violence. We're going to come on later to this issue of the relationship with mental disorders. And then there are also community-level risk factors and societal risk factors, which I've already started to highlight. But what I was interested in was thinking about what I, as a psychiatrist, needed to know. So the first thing you do as a researcher is you go and look to see what other people have done. So we went and looked at studies where a diagnosis had been rigorously evaluated using a research diagnostic interview and looked at the relationship with domestic violence. And I'm not going to talk in detail about these plots that are available in our review from 2012, but there was clear evidence from cross-sectional data that there was a relationship between partner violence, which is the main form of violence that's normally researched, and depressive disorders, anxiety disorders, whether it's lifetime since the age of 16 or whether it's recent partner violence, PTSD, not surprisingly, sometimes odds ratios, pooled odds ratios of around 7 were reported for PTSD. Sometimes people had actually looked to see what happened longitudinally. So was it the case that somebody with a mental disorder was more at risk, or was it that the violence actually led to the disorder? And actually this systematic review from Karen DeVries suggests that actually there's a bidirectional association here. Similarly, in terms of suicide attempts, some studies finding a clear relationship between intimate partner violence and suicide. Again, most studies on women rather than men. Actually, across all diagnostic categories, this association does hold, including for psychosis, but there are far fewer studies in terms of severe mental illness. There was this nice study done by Linda Teplin looking at different types of crime, looking at the National Crime Survey data and comparing it with severely mentally ill patients. But what she found was that indeed women patients with severe mental illness were at increased risk of sexual violence, but she didn't look specifically in detail at partner violence. So we tried to use similar methodology, but this time comparing with the British Crime Survey methodology, which is similar to the US survey, and asking the same questions to patients in contact with community mental health teams in North and South London. And people had to have been in contact with services for more than a year so that we had some kind of indication that these really were severely mentally ill patients. And we asked men and women because we were aware that men potentially with severe mental illness might also be at increased risk. And actually we were surprised by our findings because they were so alarming. So here you've got the female patients in contact with mental health services, and virtually 70% had experienced domestic violence since the age of 16. The comparable figure from the British Crime Survey for the general population of women was 33%. And then for the male patients, nearly 50% had experienced domestic violence. So this is in terms of being a victim. And then in the last year, 27% had experienced violence when asked, compared with 9% in the general population. And again, you can see an increased risk for the men. And when you adjust for sociodemographic factors, then actually you can still see that there's clearly an increased risk. And you might have noticed also, in terms of sexual assaults, a much greater prevalence for the women in contact with mental health services. And I'm pretty sure that most of these patients actually were not known to the clinicians as having been victims. Certainly, many of them said it was the first time they were talking about it. Interestingly, we found that actually family violence comprised a greater proportion of all domestic violence among the severely mentally ill than in the controls. And also that if somebody with severe mental illness was assaulted in terms of a serious sexual assault, then they were more likely to attempt suicide than the general population controls. We then looked at the history of childhood maltreatment because we know that it's a risk factor in the general population for being a victim, but was that also the case for these severely mentally ill patients? And indeed, there was a clear association between having been a victim of childhood maltreatment and then being an adult victim. More recently, the same PhD student that was involved in that survey did a new systematic review just looking at recent domestic and sexual violence to see whether the field had moved on and whether there was more data. And actually, still, of 30 studies that she found that had looked at recent violence, there was still a tendency not to disaggregate by gender, and there was still a tendency not to report specifically on who the perpetrator was and who the victim was. But there were 6 studies looking at recent domestic violence and 11 looking at recent sexual violence. And again, high prevalences found, rather depressingly, but also limited data in terms of what actually were the risk factors. And interestingly, less of a gender gap compared to the general population. So clearly, male patients with severe mental illness also being more likely to be victims. The other feature that we have found in these studies and other studies is that there was clear evidence of under-identification repeatedly internationally. And now, as Catherine mentioned, and I mentioned earlier, I am actually a perinatal psychiatrist. So when I was involved in a Lancet series on perinatal mental health, we were looking at risk factors in general and looked at social risk factors, psychological risk factors, biological risk factors for perinatal depression. And actually, the strongest evidence was for domestic violence. And yet this isn't something often you hear that much about in perinatal mental health settings as well. And indeed, when we did more systematic reviews, we again found evidence of the association for perinatal disorders across the diagnostic spectrum. Now, in my mental health organisation, we have a rather unique facility in that we've been completely electronic in terms of our health records since 2006, and some clever IT has been performed on our big data set of our electronic records, and they've been anonymized. So we no longer need to go out and recruit people with different conditions. We can do research on our large data set of around 250,000 patients that have been in contact with our service since 2006. So we've linked this data with hospital episode statistics, which looks at maternity data. And we've identified a cohort of pregnant women with psychotic disorders who've been in contact with our trust. And what we found was, possibly not surprisingly, that again, domestic abuse, around 20% were reporting that, and it was in the notes, which is bound to be an under-identification, but still staggeringly high, with around a third disclosing that there was a history of domestic abuse. Often people don't want to say it's present when they're pregnant because they're very worried about implications for what happens to the child. So we suspect that it's a bigger problem than that might suggest. In terms of pregnancy, we know that a history of abuse is associated with pregnancy abuse, and both emotional and physical abuse are associated with a number of fetal problems, including fetal loss, low birth weight, and premature labor. But interestingly, this link with suicide again, the US multi-state national violent death reporting system have reported that of 94 perinatal suicides, intimate partner violence was actually found in 54%. So again, there is this association with suicidality that partner violence might have been implicated in terms of preventing access to services and then preventing successful treatment. We also know that where the couple have children, the child is actually directly abused in more than 40% of those families. But of course, they're usually going to be aware of what's going on and witnessing that violence, and that we know also is associated with subsequent problems. And just some of our local patients' experiences that one of our PhD students did in terms of qualitative interviews. One of the women described being punched in the stomach when she was pregnant, one of the nurses talked about somebody that she'd looked after giving birth prematurely as a result of being beaten up, and she was mute for a month after that experience. So clearly we need to do something. There is also the impact on the child, and I don't have much time to talk about that specifically today because I am an adult psychiatrist, but using a birth cohort from South England, we've identified that clearly antenatal domestic violence continues into the postnatal period. It's associated with depressive symptoms, and it's associated with behavioural problems for the child. So what can we do about this? Well, the first issue is this challenge of identification. And in psychiatric services, as I've already alluded to, around 10 to 30% of this domestic violence is actually being detected. And a recent Australian study suggests that there's actually not very much improvement even more recently. We found in a recent study that in a local maternity population that although midwives are routinely asking, actually they're getting disclosures in less than 2%, which says something about the nature of the way they're asking, because when our researchers went in and asked the same women, they found over double of disclosures. And this study, which we've called the Wendy study, and I don't have time to describe my maternity study to you today, but we were actually doing SCID, research diagnostic interviews, on a number of women so that we could estimate the population prevalence of mental disorders in pregnancy, in fact. But one thing that struck us was that although the women were really very helpful in participating in our study, the most amount of missing data happened when we asked about PTSD. And although women had already disclosed trauma, they didn't want to go into their symptoms. So we had more missing data for PTSD than any other SCID module. And if we just looked at the data we had, then we had a prevalence of 0.78% of PTSD at the first antenatal appointment. If, however, we assume that all of those women that didn't want to answer the module actually did have PTSD, then our prevalence is over 3%, with the 95% confidence interval going up to 5.7%. So this has implications in terms of what does our research show? We're probably really not identifying all of the trauma-related disorders as well. So the National Confidential Inquiry into Maternal Deaths in the UK has highlighted a number of patterns that seem to happen when it comes to maternal deaths related to domestic violence. There are often missed appointments in pregnancy, people are quite late in accessing care, the partner is always there, sometimes preventing the woman speaking. Often there's a change in mobile phone numbers, very erratic engagement, and recurrent admissions with unexplained symptoms. So the Confidential Inquiry have put recommendations around training for maternity services, and they've given a number of key messages around what maternity services could do. So we wondered what actually could psychiatric services do, and the first thing we wanted to know was, well, why are we not detecting? So we did a qualitative study speaking to mental health professionals about what they felt about routinely asking about domestic violence as part of their comprehensive biopsychosocial assessment. And I don't have time to go into the details of this study, but what we were struck by was that they felt really uncomfortable about asking. They didn't feel they knew what to do. They felt it was not something they felt confident about, and that actually it's a social problem, maybe inquiry is not part of their role. They didn't see it was a priority sometimes, and actually sometimes the partner was there, and therefore you couldn't ask. We then asked the service users, our patients, what stopped them disclosing. And one of the main themes was fear of consequences. They were really scared that they wouldn't be believed, and in fact, some of them talked about not being believed by psychiatrists. They felt that it might result in further violence, and actually sometimes they gave stories about the perpetrator then finding out that they had disclosed and that resulting in further violence. They were very worried about statutory services, about immigration status being a potential issue for statutory services, a fear of social service involvement, that sometimes they felt that the only reason they had children still with them was because the partner was seen as the non-mentally ill person in that family, and therefore if social services were aware of the violence going on, they would potentially lose their children. And then even if they felt that actually they would keep their children, what would happen is they'd be forced to leave and move away, and that would mean huge disruption to the family. There would be huge disruption in terms of schools, loss of home, etc. They also talked about how hidden it was, that sometimes they didn't realise themselves that they'd been abused, and it took them a long time to realise that this is what was actually happening to them. There were other themes too, and there are other qualitative studies asking service users about what they would like services to be doing. And so we've done a meta-synthesis of this qualitative literature, and I won't ask you to look at this slide, but just to highlight that this meta-synthesis is there, and it focuses on what service users say they want to be done. They want it to be identified, but in a non-judgmental way. They want that their disclosures are not stigmatized, they're not blamed for it, they're actually being treated holistically, offered services that might be able to help them, and that their safety is assessed, because they sometimes feel that actually disclosing makes them more unsafe, and psychiatric services are unaware of the risks of potentially leaving. Now, we know that actually homicide is more likely after somebody has left their partner than while they're still there, and yet often the professionals are not aware of that and feel that somebody should just leave as if it was that easy. As Catherine mentioned, I've been involved in a number of guideline developments, and at NICE, we therefore recommended that certain professional groups should actually be trained and then be routinely asking about domestic violence and abuse. And we include mental health and maternity services in that because of the high prevalence of these problems in our service users. We're not talking about screening, which is something that causes extraordinary amounts of heated debate sometimes, because actually this is part of what we should be doing as our comprehensive assessment anyway. We ask about relationships, so why would we not be asking about what happens when people disagree, what happens when people start to argue, does it ever lead to physical violence, etc. And unless you start routinely asking, then actually you're not going to get these disclosures. WHO have made similar recommendations, and the World Psychiatric Association have now produced a curriculum, a competency-based curriculum, which highlights what medical students, psychiatry trainees, and consultant psychiatrists need to know. And that ranges from what immediate psychological management should be in terms of being non-judgmental, making sure that they are assessed in terms of safety, assisted with referrals, and also help to understand the effects of trauma, and also talks about considerations in therapy in terms of recognizing the connection of symptoms with trauma. Again, this issue of safety, this issues of difficulties with trust, because people have not been able to have healthy relationships, often in childhood as well as adulthood. The essence of all of these recommendations are around making sure that people understand the safety issues and building a collaborative relationship to work together on how best to manage that situation. And I do also wonder about the impact of domestic violence and abuse on our treatments anyway, because if we don't know about it, is it that the treatment-resistant depression is actually because the person is being abused? And at the moment, we're doing a systematic review to look at domestic violence and abuse as a moderator of mental health interventions. So moving on to interventions, there's been a Cochrane review of interventions for domestic violence in pregnancy with 10 trials, just over 3,000 women. Not great evidence in terms of the quality of the trials, but there is some evidence that an integrated psychological intervention, which addressed not only domestic violence, but also low mood and other risk factors, was associated with reduced abuse. And some of the other trials, some of which weren't included in the Cochrane review, do suggest that interventions can be helpful in improving the extent of the abuse, although they tend to be underpowered. There is also a trial that we are currently submitting, which has actually skilled up the domestic violence advocates to deliver psychological interventions themselves, and that did actually show evidence of improvements in mental health as well as abuse compared with domestic violence advocates who weren't skilled up. So we've been trying to integrate our interventions for antenatal depression, not only to address the depression, but also to address other risk factors, such as intimate partner violence. This is actually quite a low-intensity intervention, which is offered by psychological wellbeing practitioners, as they are known in the UK. These are people in primary care psychological therapy services, and they offer guided self-help. They're not highly skilled psychologists, but they are a low-intensity intervention, usually using some kind of workbook. So we developed a workbook, and we wanted to make sure that in the section around managing relationships, we explain what abuse is and where people can get help, and that this is asked about by the therapists. At the more systemic level, there has been a large cluster trial in the UK of primary care practices. And this was carried out by Jean Fader, a colleague in Bristol, and published in The Lancet several years ago now. And what they did was they had domestic violence educators. These were domestic violence advocates who were linked with the intervention practices. They would train the whole practice, from the receptionists to the GPs to the nurses. And they were also there as somebody who the GP could refer to. So the GP didn't need to think, I don't want to identify this because I don't know what to do about it. There was actually a referral pathway. And as you can see in this plot, that in the control practices, there were relatively few identifications and very few referrals to services, whereas in the intervention practices, there were significantly higher levels of identifications and referrals. Now, this assumes that referrals are actually going to lead to improved health outcomes, which actually they weren't able to measure. So when we modified this intervention for community mental health services, we were really keen to also measure health outcomes. And from my experience working many years previously on IPS, individual placement and support, I was very aware that unless you really integrate services and actually have people within the community mental health teams, then sometimes things don't work so well. So some of you may be aware of the IPS literature in the States and may be aware of a trial which actually showed that IPS didn't work in the UK. That was our trial. And from our process evaluation, what seemed to be the case was that the reason it hadn't worked was because we just hadn't managed to actually get all of that integration in the way that some of the US trials had done. So I was really keen that we properly integrated the domestic violence sector with the mental health sector. So we arranged for a secondment of these domestic violence advocates or advisors, as they're known in the UK. And we did reciprocal training. So they trained the community mental health teams, and the community mental health teams trained them to understand more about mental disorders and about the rather intricate systems that we have in terms of our complicated mental health services. So they could understand what detention under the Mental Health Act meant, what medications might do in terms of side effects, and also the complexities of assessment. So we integrated these advisors into intervention teams and had control teams, and we wrote a manual, which we then wrote up as a book for community mental health teams in the UK. And what did these advisors actually do? Well, what they offered was not only training of the teams, but anybody that was referred might get any of a range of interventions. So they might, of course, be referred to safe houses, but they also knew about lock fitting schemes, about legal options that we didn't actually know about. They knew how to do really comprehensive risk assessments and safety assessments. And, of course, they were there all the way if somebody wanted to take things to court, and they were able to actually offer support around taking something to court. And we had a really interesting case of somebody with bipolar disorder who saw in the community mental health team base the advert for our study, and she asked to be referred to the advisor. And she, every time she got acutely ill from her bipolar disorder, would contact her ex-partner, and he would come round, and then he would actually rape her. And she had wanted to actually take this to court, and the mental health professionals felt that, you know, she was ill and that actually the court case wouldn't go well, but she was stable and she really wanted to take it to court. And the domestic violence advocate actually said, yeah, we'll support you, we'll take it to court. And when it actually got to court, it turned out that actually he had a history of doing this with vulnerable women. And he was sent down. And that caused a major shift in terms of how the domestic violence sector had conceptualized this rather differently to the way the psychiatric system had conceptualized it, and led to more discussion of some of these really complicated cases, when actually it is really difficult to know what would be best, but to help service users really think through their options. So qualitatively, service users talked about the things they liked around this intervention. They liked the fact that actually something happened when they disclosed. There was actually something that happened in terms of a referral, that the abuse was being documented, that safety seemed to be more secure, and support seemed more integrated. But it's always important to ask what doesn't go well when you're developing an intervention. And they also talked about not wanting once they had disclosed, for the professional to say, well, unless you leave, I can't work with you. They found that really unhelpful. And they also felt that sometimes there was a tendency of professionals to no longer want to discuss the domestic violence because there was an advocate they could talk about it too. And there was a bit of a separation there that actually the service users felt would be more helpful if they could also still be discussing it. Now, what we found was that actually there were more identifications in our in our intervention teams than our control teams. So few identifications in our control teams, in fact, that we couldn't really do very much in the way of much statistics around our pilot. But what did seem to be the case was for those that were identified, there was a reduction in abuse and improvements in mental health and quality of life for people in the intervention teams. So we're now doing a cluster trial of this intervention in the Netherlands, having not yet managed to persuade our English funders to give us money to do this trial. Now, if you actually go back to what NICE is recommending, I don't know if you can see this at the back, but there's lots and lots of recommendations around what to do around victims. And there's very little around what to do about perpetrators. In fact, really, there's just one set of recommendations, which are here. And what this says is commission and evaluate programs for perpetrators. And that's because there isn't great evidence that perpetrator programs are that effective. And yet everybody felt, surely we need to do something about perpetrators and not just focus on the victims. And it was therefore decided at NICE that if perpetrator programs were going to be commissioned, then they should always be evaluated in terms of outcomes. Now, coming on then to what should we be doing as psychiatrists around perpetration of domestic violence, again, we went back to the literature and again found an association between being a perpetrator of intimate partner violence and having a mental disorder. And again, it was across all diagnostic categories, but far less data and a lack of data on whether substance misuse was involved and under all of the other types of confounders that might be of relevance. What we also found in the literature was that more than 80% of perpetrators for domestic violence homicides were men. So there clearly, again, was a gender element, even though when it came to lower level violence, it seemed that both men and women with mental disorders could indeed be violent, as I'm sure this audience knows. And we also found in a separate systematic review looking at partner violence perpetration for men who have sex with men, an association with substance misuse. There have been multi-country studies also looking at perpetration in general, looking at risk factors, and again, alcohol misuse is often talked about, a history of trauma, often depressive symptoms are identified, and again, this issue of witnessing parental violence as a child, along with the societal issues around whether or not there are inequitable gender attitudes. So what is the causal pathway here? And this has been debated in the literature. Is it that childhood maltreatment is associated with the development of a mental disorder and also potentially perpetrating violence? Or is it that substance misuse is somehow mediating that relationship? In fact, this morning I was sent a new review by one of my new PhD students who'd found that there's a review on ADHD in childhood being associated with partner violence. So are we missing some elements of psychopathology that could actually be treated, which could be potentially helping in terms of reduction of perpetration? What we found in a primary care survey, and this was done in Bristol, was that when asked about negative behaviours, so not specifically calling it violence and abuse, but asked about various negative behaviours, then actually 16% of men reported having perpetrated negative behaviours, and there was, again, an association found with depressive and anxiety symptoms on the Hospital Anxiety and Depressive Scale. So coming back to what psychiatrists can do, though, we were wondering about this issue of domestic violence homicide. And in the UK, there's a national confidential inquiry into suicide and homicide by people with mental illness, which was set up by Lewis Appleby, who luckily was my other PhD supervisor. So I asked him if I could have a look at this data in terms of intimate partner homicides, which he hadn't actually ever looked at, but there was a question about who was the victim. And we found that when it came to intimate partner homicides, around 20% of the perpetrators had symptoms of mental illness at the time of the offence, mainly depressive, but also some psychosis. Not hugely different to the general data set around homicides in general. So intimate partner homicides did not look like there was a greater amount of mental illness compared with homicides in general. That wasn't the case for the family homicide perpetrators. There was actually a considerably more psychosis at the time of the offence documented for actually a third of the adult family homicide perpetrators. But actually for both the intimate partner homicides and the family homicides, most of these people had not been in contact with mental health services in the year before the offence. So not much that the mental health service could have done because most of them were not in contact. Some were, though, and it is striking now that we have domestic homicide reviews in the UK that sometimes you can see that domestic violence hasn't been thought about when doing risk assessments in psychiatric services. We know, for example, from this data set that in terms of the victims of homicides committed by psychiatric patients, 19% are intimate partners or ex-partners. Now, in 2011, Theresa May, when she was the Home Secretary, introduced statutory domestic homicide reviews. And she's actually passionate about domestic violence, actually probably not very passionate about Brexit. But she actually, one of the only other bills that's due to appear in Parliament if she carries on to next year is actually a domestic violence and abuse bill. So she's very interested in this area. And the Home Office, under her leadership, looked at domestic homicide reviews and did analysis of the first 94 that were completed. And what she found was that professionals did not seem to be aware or understand the complexities of domestic violence. There was a failure to risk assess, there was a failure of information sharing. In the UK, we have multi-agency risk assessment conferences specifically for domestic violence, and they're supposed to be attended by mental health services, but at the time they weren't being attended by mental health services. And there's often been a focus on mental health needs or substance misuse needs, but not a consideration of domestic violence by the mental health professionals. Substance misuse, in fact, was a common theme, often mentioned in these domestic homicide reviews. Another analysis, more recent, of the domestic homicide reviews done by an NGO found that 2/3 of the victims and 2/3 of the perpetrators had some form of mental health need that had been documented somewhere, usually in primary care rather than secondary care. So we're hoping to actually look at the growing body of domestic homicide reviews, to actually look at what happens when people had been in contact with mental health services, to see if there are some lessons that can be learned. But from what we can see so far, the most common theme in all of these analyses is that record keeping could be improved. It's not great. People are not specifically recording whether or not domestic violence was even asked about. There seems to be a failure in risk assessments to actually identify a history of domestic violence. And in fact, a domestic homicide review in our local mental health organisation involved a patient who was admitted to an acute ward, acutely psychotic, and when he went on leave to be with his new partner, he killed her. And even though 4 years previously, when he'd been acutely psychotic, he'd been seriously violent to an ex-partner, that hadn't been thought about in relation to his new partner when he went on leave. There had been no record in that new admission of that history. Probably nobody had asked him and nobody had managed to read through the reams of notes, but clearly if somebody had thought about that, they might have thought twice about him going on leave. There's also been a problem of communication and information sharing between agencies, often where there was a presentation to agencies around domestic violence and abuse, but it wasn't explored further. And what most commonly was recommended was more training. So where are we at with severe mental illness and domestic violence perpetration? Well, I don't think we know the extent to which our patients are actually potentially perpetrating domestic violence and abuse. I'd rather that we didn't have to talk about it, in the same way as I think we don't really like to think that much about violence and severe mental illness, but we know that there is a link. Patients are more likely to be victims in general than perpetrators, but there is sometimes an increased risk of violence, but we don't know the extent of domestic violence because it's just not been recorded or investigated. We're not clear about the pathways, and more importantly, we actually don't know whether treatment is going to make a difference. We know that it can make a difference for violence in general, so maybe it could for domestic violence too, but we don't actually know enough about what's going on for our patients. But what we do know also is, as I've already mentioned, risk assessment is problematic. And we recently did a study asking about identification of domestic violence perpetration to our mental health professionals in some other organisations. And actually some of the themes were again similar. A concern about roles and responsibilities, that it not being part of routine practice. People weren't specifically asking about ex-partners. They were only asking about risk to current partners. A reluctance to label service users as potential perpetrators, poor information sharing, and a lack of treatment and referral options. When we at NICE looked at the evidence around interventions, we found that although there is some evidence for improvements in attitudes of perpetrators, there's not a great deal of evidence for improvements of actual violent acts. And there are currently some new reviews looking at substance misuse and perpetration of violence. And again, not very many studies, some pilots, mainly from the state. Rochester in New York is particularly interested in this area, and they've developed some CBT interventions for perpetrators with substance misuse problems. But there's still a bit of silo working there in that people are not focusing on the mental health, they're focusing on the substance misuse, or they're focusing on the perpetration, but they're not focusing on the trauma. And nobody's really bringing it all together. So Jean Fader in Bristol, Gail Gilchrist in London are working on some potential interventions. And there's a really interesting new intervention that we're actually evaluating. We've not been involved in its development, but it's actually for couples where the woman is pregnant and both the man and the woman want to be involved in parenting of this child, and where they've both admitted that there is violence, whether that's mutual violence or particular violence from one to the other. And they're offered separate interventions. It's a very intense program with a lot of psychotherapy, group and individual work. It's very much trauma-informed, both for the perpetrator and for the victim, and using a lot of evidence-based strategies, and we'll see whether that actually can make a difference. And we're also doing some funded work looking at whether targeting certain mechanisms, such as treating psychosis, would actually make a difference to some of these acts as well. So to conclude, domestic violence is unfortunately associated with mental disorders in both men and women, although we know that women are at greater risk of being a victim of severe abuse and men are at greater risk of perpetration, but both can be victims and both can be perpetrators. We also know that domestic violence and abuse has been under-detected by mental health professionals, and we could improve our response. And we need to be thinking about domestic violence as a potential moderator of engagement as well as treatment response. We in the UK certainly have a long way to go in terms of training and people being more knowledgeable, but we are now starting to get it into the psychiatric curriculum. And it may be that system-level interventions, such as integrating domestic violence advocates, could improve rates of identifications and referrals, and that might improve outcomes. But certainly, as a researcher, of course, I'm bound to say that more research is needed. But I think I wanted to finish by mentioning the American Journal editorial that I saw in 2015, and there aren't that many people working on this. So it was really exciting to come across Catherine's editorial, where she talked about the fact that actually we really do need to understand and rehabilitate both the perpetrators and the victims without prejudice. I'm just going to leave you with some resources before we get into a discussion. There's the WHO guidelines, which I mentioned, the World Psychiatric Association curriculum, And there is also a Lancet series, which people at the WHO and other leading researchers were involved with in terms of health systems change. But finally, most importantly, I wanted to acknowledge the people that have been doing all the work on these studies, and thank Catherine for inviting me. Thank you.
Thank you so much for really Louise's terrific talk. And it's our habit now, to, as you know, to have a bunch of questions. And just wanted to emphasize that this initiative that we have here at Columbia around domestic violence was really intended to both bring the topic of domestic violence into psychiatry, and there still really is a need for that, and you just did such a fantastic job of bringing it to us. And also then to work the other way, which is to bring psychiatry and some of its resources and expertise into domestic violence care. And we're hoping we're doing that, and that you're helping spearhead bringing the groups together. I'm going to actually take advantage of having the mic and ask the first question, which is really, we touched on it last night, but about having two of the different groups come together, that being the advocacy and psychiatry. And with the bipolar case you mentioned, really illustrated some of the pluses of that. But I wanted to ask you a two-part question. One, what are some of the barriers of the two groups working together? And then just a sub-part, something that's come up for us clinically, and Mayumi Okuda has really described this, where a patient is getting very good care, mental health care, has made a resolution to make a change legally, perhaps, around the domestic violence situation. The demands of the legal aspect to recall what has gone on is actually, can be very exacerbating for PTSD symptoms, et cetera. So sometimes on the personal level, these two worlds coming together can present challenges.
Okay. So I think the challenge has been for us working with the sector is that we've had traditionally such different models of domestic violence and abuse. And the domestic violence sector in the UK did not like the medical model. They saw things in terms very much of gender-based violence and symptoms being understandable reactions that didn't need psychiatry. They needed domestic violence advocacy and a change at the societal level. And one of the challenges of working at NICE is that you bring a whole load of stakeholders together into one room, and you all have to reach a consensus on your recommendations, which is a great way of having to discuss these issues, because we all knew in this room that we all wanted recommendations. The recommendation that actually caused quite a lot of controversy was around mental health interventions. And that was because the domestic violence advocates that were in the room were very concerned that people would be labelled as having a psychiatric problem, and therefore their other needs were not going to be addressed. And it is really difficult, which is why I felt so strongly that we needed to integrate the advocates, that unless we all learn to start discussing cases so that we could understand each other's viewpoint, we weren't going to be able to help individuals, but also help in terms of guidelines. So I think it's coming from very different perspectives, but I think that we can meet. But I think there's some interested hands at the back there.
Yeah, this is well, not specifically a mental health question, but it would certainly be something on the minds of someone treating someone where this history did come out, and that is, do you have any data on how many domestic violence situations ultimately result in a homicide? I'm thinking of the Pistoria, the ongoing and forever Pistorius case, for example, in South Africa. But how many are there data on how many turn out like that? It's like with suicide, you know, you do risk assessments, and the question is, how concerned should you be, and what are all the factors? So this is the worst possible outcome, obviously.
So in the US, there are 3 domestic homicides a day, apparently. In England, there are 2 a week. Now, that's partly because there are more homicides in general in the US, which we across the pond think is partly to do with gun control. And so it's a common problem. What we don't have that much data on is how many of them, for how long, had actually been experiencing violence before, which is what your question is asking about. And what I'm interested in is what about the ones that have been in contact with psychiatric services? And that's why we looked at this National Confidential Inquiry data, because we wanted to see how many had actually been in contact with mental health services. And actually, it was a relatively small proportion. Having said that, we all know also that risk assessment is a very imprecise tool. And whatever standardized assessment or clinical assessment you use, we know that we're not that great at identifying risk of homicide in general, and I suspect that the same is true for domestic violence homicide.
Yes, I wanted to ask a question. In the past, we had a psychiatrist, at least in New York, who worked with the police. There's oftentimes the neighbors and other people get the ball rolling. And I wonder, along with the differences in gun violence that you mentioned, what role the police have in England and what do neighbors do and how do you deal with the police? They're another party to what goes on. So what is the practice in London or Glasgow or whatever in terms of the role of the police in getting the ball started?
Yeah, so there's been a huge amount of interest in what the police could do differently over the last 20 years or so. And since 2005, there have been the implementation of multi-agency risk assessment conferences, and they're led by the police. And the idea of them was to get all the relevant services into a room to share information, because housing might know about lots of complaints from neighbours, and the police might know about a conviction history that nobody else knew about. So these MARACs, although there's never been a trial of them, are thought to have been effective in the type of evaluations that have been carried out. They were actually developed by Cardiff University in Wales, and they've now been rolled out across the country. And these domestic homicide reviews identified that although all the relevant parts of the health sector are also supposed to be there, traditionally mental health services were very absent. And I think that has definitely changed. Certainly in our organisation, we now have 4 different reps going to the different boroughs. They meet sometimes once every 2 weeks, sometimes once a month. But the startling thing is how many of them have actually had contact of the victims and the perpetrators with our services at some point. Sometimes it's as children, not necessarily recently as an adult, but clearly the more we look, the more we're finding. So in those sort of situations, all of the agencies have to sign a document around confidentiality and information sharing, and then the group come to a decision about what should be the action plan. And as I understand it, some of these multi-agency risk assessment conferences work better in some parts of the country than others. I think in South London, actually, we have got some very good practice now. And I don't know if you have a similar type of initiative here.
Maybe the commissioner would like to speak on that.
So first of all, I'd like to just address your question about the numbers, because I think that's important and when we think about New York City. So when the police go out on any case, you call 911 and you say this is domestic violence and the police come, they're required to fill out what's called a domestic violence incident report. And that report is done on every call, whether it's something major, something minor, they do it on every single call. When you look at that number for 2016, it's over 290,000 DIRs, okay, right, citywide. Now let's break that down a little bit, right? So that's everything. That's child abuse, that's elder abuse, that's, I can't control my son, that's, you name it, that's all of it. When you look at intimate partner violence, it's over 91,000. Right? And last year we had 38 homicides. 38 homicides. intimate partner homicides. The overall homicide number is larger, but intimate partner homicide. So those are the numbers that we're looking at, and I would encourage you to go to our website. And we just put up our recent fatality report that speaks to the numbers, and you can see what that looks like citywide. But citywide, it really is a significant issue in terms of both the incidence, the prevalence of that, and then the homicide number. But there's also a great deal of harm that happens in between incident and actual death. You can have major illness and gunshot wounds that you don't die from, right? You have all kinds of other injuries that don't necessarily result in the homicide, but are significant. And they're significant of the overall numbers in terms of felonies and things like that. So I wanted to say that. Then the other question was about the interdisciplinary teams. And I think this example that we're talking about here today in terms of the Domestic Violence Intervention Program with Dr. Monk and Dr. Fiddleston, the team, are a wonderful example of what that is, because when you think about our Family Justice Center, the space itself is an interdisciplinary team. We have, in that space, we're co-located with the District Attorney's Office. So the prosecution of the case is going on right next door, and those lawyers managing that are right next door. You have civil legal attorneys who are there to represent the client and the client's interest in moving forward in whatever aspect that might be. They're immigration lawyers, they're case managers in that space. And so the space itself is an interdisciplinary space. And the addition of the mental health component makes that collaboration even stronger, because what you have is now the actual conversations that can happen, the sharing of information, the dialogue, the case conferencing around very difficult and challenging cases, and how can we make that work in the best way possible. And finally, the other issue I think that was brought up, and I think by you, Catherine, and really well, is relates to how mental health is seen in the court system. And when children are involved, that can be very challenging for a survivor. To have that be documented, especially when you're going into custody battles, is very, very challenging. And how the team collaborates, how the team really works together to figure out, one, let's make sure a treatment model is here. What do we document? How do we document it? And prepare to manage that in a custody case. That's what's most important. And that's what this collaboration really achieves in just a stellar way.
Thank you, and thank you, Dr. Howard, for such an overwhelmingly informative talk. I wanted to address just two comments and then switch gears for my question. One comment, the Commissioner, so grateful that you're here. I just think that every clinician here should understand that the Family Justice Centers are walk-in centers, 9 to 5, Monday through Friday. There's one in every borough. If you have a client, in addition to the wonderful Dove services we have here at MIP, if you have a client who's struggling with an issue with intimate partner violence, or elder abuse, they can walk in 9 to 5 and get linked to a case manager right away and get linked to services. It's a wonderful resource. You can look up the OCDV website for all the information. The second is around the risk assessment, and I think one of the questions, the underlying questions is, well, if we have a patient who reveals that she's in a domestic violence situation, what's her risk? I would point you to the Jackie Campbell's danger assessment tool. It's a really useful tool that has a number, in the same way the Columbia Suicide Scale is very helpful in terms of assessing suicide. I think that tool can actually be quite helpful for clinicians to really understand the risk that their clients are in the context of a relationship. And there's a whole other wealth of resources too that I think are helpful for clinicians. So, oops, I'm covering it over. I want to switch gears a little bit for my question for you. And one of the things that we've noticed and Dr. Akuda and Dr. Berry and Rosa Vajinkos and I have talked about a lot is the number of times we've seen clients at the Justice Center or in other circumstances who come in with a diagnosis of bipolar disorder or schizophrenia, but when you actually talk to them and ask about trauma and ask about their history, it really is clear that what they're suffering from is some complex trauma picture, and the diagnoses are not actually descriptive of what's going on. And I wondered if you can comment on the implications for our under-recognition of intimate partner violence, domestic violence, and trauma on our actual ability to care for our patients.
That's a really interesting question. I mean, just aside from partner violence, I think trauma in general is something that certainly we in the UK are still not getting right in terms of understanding the psychopathology that's in front of us in the clinic. One of the cases that instantly came to my mind was a woman, and I'm going to change some of the details slightly in terms of identifiable characteristics, but somebody that came to the clinic who'd been in the forensic psychiatry system, who had a diagnosis of schizophrenia and was on clozapine. And she was pregnant, and she'd instantly stopped her clozapine because patients know they don't want to expose the pregnancy to drugs. And the rehab team wanted to know, was it okay to put her on olanzapine or not? So it was a great opportunity to review the diagnosis. And she had the most horrendous trauma history, which was well known about, but absolutely awful history of her mother, who'd been a prostitute, being murdered in front of her when she was a young child, and terrible care experiences. And she'd ended up actually in the criminal justice system for arson in her teens, a lot of substance misuse, lots of psychosis, and she'd ended up in the forensic psychiatry system for about 8 years. And her first baby had been removed. She'd had the baby with a forensic psychiatry patient. Horrendous history. But actually, the rehab team was saying, she actually hasn't had any active symptoms for about 5 years. So, well, has she actually got schizophrenia? And actually, the more we looked, the more we thought, well, there's always been substance misuse around in the past. And of course, she was so motivated to be as well as possible because she so wanted to keep this baby. And luckily, she had a very, very strong social network of, because she'd become quite religious and had a very, very protective social network. And actually, we ended up deciding with the team that actually we had to reconsider the diagnosis, that she'd had these terrible traumas, and she had experienced severe symptoms at times, whether or not they were at the time related to substance misuse. But actually reconceptualizing her problems in terms of the trauma she'd suffered was helpful for all of us thinking about how to best support this young woman, and also not putting her back on clozapine. So I think that we do need to be always rethinking quite what's gone on in patients' lives in relation to what they're presenting with.
Other questions? Yes, I'm sorry, the man in the tie, I'm sorry. Yes.
Hi, thank you. That was a really fascinating presentation. This is related to Dr. Fiddleston's question. One concern I always have when we talk about mental disorders in relation to DV is that mental disorders tend to pathologize the individual, with the rare exception of PTSD. And I think that the Family Justice Center model is one way of addressing that, where we do work with advocates, so we're not just saying, you can take care of this yourself, this is your problem. But I was wondering if you have any other thoughts about how we can really make it a community intervention rather than an individual intervention, in addressing this issue in larger ways.
So I'm not entirely sure I understand your question. Are you asking about the value of diagnosis or about...
Yeah, about diagnosis itself. I mean, if I were to rename it DV-related depression, that's very different from depression,
I think, when one starts in psychiatry, one is continually questioning the whole concept of diagnosis, and maybe one continues to talk about its values and also its potential limitations. And I think you're highlighting that there are limitations. These are constructs, syndromes, And they do have their use, because we know that certain syndromes will respond to certain types of interventions. Sometimes it's helpful to actually give them an actual label for all sorts of reasons, and sometimes it's less helpful. I think it's a shame, though, for it to be instantly thought of as pathologizing, because actually what we're doing is we're just describing an operationalized system of symptoms, and I think maybe that's partly reflecting society and the stigmatization of mental health problems, rather than actually saying that all that we do is unhelpful in terms of diagnosis. I still actually do find diagnoses helpful. And I think that the tendency to say that's pathologizing, it's actually just describing. It's a bit like the whole debate around personality disorder. I mean, one can either choose to use a term in a report or not, but actually you're also going to be describing what the problems are. And I think that is useful, because people need help with those symptoms. Does that answer your question?
There's another man with a tie on. Yes.
So I wonder if you could say something about the therapeutic interventions with the perpetrators. What sort of thing is done? I've heard the counterintuitive statement that these are actually emotionally weak people, certainly not strong, and they keep losing arguments verbally, and they don't know what to do, and they just explode, and that the approach to them is actually supportive, which seems, the opposite of our feelings is that they're hateful and they should be punished, or someone should take a very stern and critical hand to them. So beyond Prozac, what do you suggest in terms of a therapeutic intervention?
As a perinatal psychiatrist, personally, I don't see that many who are actually my patients. But I guess it's the same as psychiatry in general, seeing patients who might be violent, in that we're talking about addressing their symptoms and what could be helpful. What I think is difficult when it comes to domestic violence is that there is a tendency, and I think this comes back to Catherine's editorial, there is a tendency for society to say, right, they're bad and they need, as you said, strong, prison or whatever. And actually, why are these men behaving this way? And often it's because of trauma in their childhood, and actually we need to understand that and treat it. And I think that's what's so interesting about this intervention that's actually been funded through a philanthropist who was passionate. I don't know quite what his own issues had been, but he was passionate about trying to address this very early. So, in pregnancy and early childhood, to stop the next generation of children witnessing violence. And the fact that he felt that what was needed was for the perpetrator as well as the victim, for both of the man and the woman, to be offered trauma-informed care, while also being prepared to say, yes, this is violent and this is unacceptable and it's bad for the children. Because even, many people are prepared to think again when it comes to knowing that there is harm for their children. And we've been debating in England, there's been a women's mental health task force set up, and there's been a debate as to whether a public health education campaign could be useful in terms of educating the public to think, actually, violence in the home is really damaging for the children, because nobody wants their children to be damaged, and it might be a great way of intervening to try to break that cycle.
Other questions from someone who hasn't had a chance yet? Ralph, is that another?
Well, I would say domestic violence has other dimensions besides the violence. It's extremely difficult to get people who are living together and tolerating the violence. Now, in one case, a couple of cases I just mentioned as a clinician, and one was a man who was with a woman who I told him, this woman is going to kill you. You have to leave. And he didn't take my advice. I had him see a second doctor who told him the same thing, and he was killed by this woman. Another case, the other reverse, but there was something of an intimate nature going on between the two of them, but they refused to separate. Another woman I saw was being abused by her husband. There were two little boys in the situation. And I told her repeatedly, you've got to save your children. It took them 5 years before they finally get separated. But meanwhile, the children have witnessed a lot of violence. These are very tough cases. And counting the numbers is one thing, but trying to separate people is an extremely challenging job. So I would say that's another part of it, because the other dimensions of what goes on, the violence is the surface. Deep down, there are profound issues historically, as you're saying. So I just mentioned the clinician's view, not the numbers.
Yeah, no, I completely agree. These are really complicated cases, and there isn't, I think maybe that's why we have such problem as agencies discussing them, because we see things differently, and actually there isn't a simple answer. If it was as easy as leaving, then actually everybody that would be the end of it. But it's not easy at all, for all sorts of reasons, for both of the people in that relationship. So I think, we've started to discuss these cases. I think that we just have to keep thinking, and that we've developed some expertise and some experience, some things that have worked, some things that haven't, and we have a very wise nurse who's been around for a very long time, very senior nurse, and when there's a particularly challenging case in our organisation, we all sit round and discuss it with her, and I think that's what the team are doing here as well, that actually there isn't a simple answer, and we all need to be thoughtful about it, but just a sort of instant, I'll refer to social services and that's the end of the children's problem, it's not going to be. It's just not that simple. So yeah, it's really complicated, and systematic reviews are not going to solve the problem.
I just want to add a last comment, because I think we're winding up, that so many times we've touched on really underneath, without labeling it, development. So when you talk about past trauma in both the perpetrators and the victims' past, to me, and this gets at Ralph's point about the historical aspects and complexities, is that with any diagnosis, it's also useful not only to use it descriptively, but as a question mark to say, from whence did this come? How is the person's past, the violence they've already experienced as a child, get them to where they are now, or to be a perpetrator? Let's understand this developmentally too. It's so important. And then do prevention. So that's right. So I think we should give